Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 352 of our pharmacotherapy series, which majors in asthma. My first question to you applies to the case of patient QCI in part 351 of this pharmacotherapy series. Why was a short-acting inhaled beta-2 agonist selected as the bronchodilator of first choice in preference to other bronchodilators such as aminophylline or ipratropium for QCI? Because of their potency and rapidity of action, short-acting inhaled beta-2 agonists, abbreviated as SIR-BARs, are considered the first choice for the treatment of acute asthma. The bronchodilatory properties of short-acting inhaled beta-2 agonists are particularly effective in reversing early-phase asthma responses. Aminophylline, which is a thiophylline salt, is not as efficacious and has more risks for serious adverse effects than inhaled albuterol. Similarly, the bronchodilation from the anticholinergic drug ipratropium is of smaller magnitude than with inhaled short-acting inhaled beta-2 agonists. However, two double-blind pediatric trials found that the sickest children had a reduced rate of hospitalization if given ipratropium with albuterol in the accident and emergency department. In one trial, children with baseline forced expiratory volume in 1 second less than 30% of predicted value had a reduced rate of admission with ipratropium, and in the other trial, children with baseline peak expiratory flow less than 50% had a reduced rate of hospital admission. Consequently, although early addition of inhaled ipratropium in adequate doses to short-acting inhaled beta-2 agonists will improve pulmonary function tests and reduce the rate of hospitalization in severely ill patients, QCI's physician chose to use only inhaled short-acting inhaled beta-2 agonists initially because QCI was not severely ill. The next question: what is the preferred route of administration for short-acting bronchodilators? It is well documented that short-acting inhaled beta-2 agonists administered by the inhaled route provide as great or greater bronchodilation with fewer systemic side effects than either the parenteral or oral routes. In situations of acute bronchospasm, concerns about adequate penetration of aerosols into the bronchial tree led many clinicians to believe that the parenteral route of administration would be more effective than the inhaled route of administration. In clinical trials, however, inhaled short-acting inhaled beta-2 agonists were as effective as the standard treatment of subcutaneous epinephrine for accident and emergency department treatment of acute asthma in adults and children. Therefore, Aerosolized short-acting inhaled beta-2 agonists now are considered the agents of choice for accident and emergency department or hospital management of asthma. Beta-2 agonists should not be administered orally to treat acute episodes of severe asthma because of the slow onset of action, lower efficacy, and erratic absorption. QCI received albuterol by nebulization. So my next question to you reads, would metered-dose aerosol administration of the short-acting inhaled beta-2 agonists have been preferred? Is the dose given by nebulization the same as that given by a metered-dose inhaler, abbreviated as MDI? Aerosols are mixtures of particles, e.g., a drug-lipid mixture, suspended in a gas. A metered-dose inhaler consists of an aerosol canister and an actuation device, that is a valve. The drug in the canister is a suspension or solution mixed with propellant. The valve controls the delivery of drug and allows the precise release of a pre-measured amount of the product. A second aerosol device, the air jet nebulizer, mechanically produces a mist of drug. The drug is placed in a small volume of solute, typically 3 ml of saline, and then placed in a small reservoir, that is a nebulizer, connected to an air source such as a small compressor pump, oxygen tank, or wall air hose. Air travels from the relatively large diameter tubing of the air source into a pinhole-sized opening in the nebulizer. This creates a negative pressure at the site of the air entry and causes the drug solution in the bottom of the nebulizer reservoir to be drawn up through a small capillary tube where it then encounters the rapid airflow. The drug solution is forced against a small baffle that causes mechanical formation of a mist. An ultrasonic nebulizer is a type of nebulizer that uses sound waves to generate the aerosol. Studies that compared nebulization with pressurized metered-dose aerosols in stable chronic asthma patients have shown no advantage among these methods of administration when equivalent doses are administered. Trials comparing metered-dose aerosols of inhaled short-acting inhaled beta-2 agonists with the nebulization of those same drugs in acute asthma also have shown no significant advantage for the nebulization method of administration when the metered-dose aerosolized administration was carefully supervised by experienced personnel and a spacer device was used. However, in some younger acutely ill children, it is difficult, even with supervision, to administer an effective short-acting inhaled beta-2 agonist with a metered-dose canister. Because many patients and clinicians perceive that nebulizers provide more intensive therapy, it often is important psychologically to give at least the first dose of a short-acting inhaled beta-2 agonist via a nebulizer. Thereafter, it is more cost-effective to use the therapeutically equivalent metered-dose inhaler plus spacer. The dose ratio for short-acting inhaled beta-2 agonists delivered by metered-dose inhaler plus spacer versus nebulizer has varied in the literature. For children with mild acute asthma, 2 puffs of albuterol metered-dose inhaler attached to a spacer were not different from 6 to 10 puffs of albuterol or via nebulizer 0.15 mg per kilogram. In one double-blind trial in children with a severe exacerbation, investigators used a dose ratio of 1 to 5, i.e., albuterol metered-dose inhaler spacer 1 mg, that is 10 puffs, nebulized albuterol 5 mg. Nebulization of albuterol with compressed air or, preferably, oxygen was the preferred method of administration for QCI initially. Starting 20 minutes after the first albuterol dose, 2 more doses of 2.5 mg of albuterol were administered by nebulizer every 20 minutes during the next 40 minutes. After 3 treatments, QCI's breath sounds became increasingly clear. She was no longer in distress and could speak in complete sentences. Her peak expiratory flow was now 70% of predicted. Her arterial oxygen saturation was 97% on room air, and discharge to home was planned. So my question to you is, were the dose and dosing interval of albuterol appropriate for QCI? Xu and colleagues demonstrated that a higher dose albuterol regimen, dosed at 0.15 mg per kilogram versus 0.05 mg per kilogram every 20 minutes, produced significantly greater improvement with no greater incidence of adverse effects. Xu et al. Subsequently reported greater efficacy of albuterol in a dose of 0.3 mg per kilogram, up to 10 mg hourly compared with a dose of 0.15 mg per kilogram, up to 5 mg hourly in children. The larger dose was tolerated as well as the 0.15 mg per kilogram dose. Therefore, QCI's albuterol regimen of 2.5 mg, i.e. 0.13 mg per kilogram, nebulized 20 minutes for 40 minutes subsequent to her first dose of aerosolized albuterol could have been even more aggressive but was appropriate. My next question to you reads, would another short-acting inhaled beta-2 agonists have been more effective in the initial therapy of QCI? Short-acting inhaled beta-2 agonists, e.g., albuterol, are preferred over nonspecific agonists, e.g., isoprotronol. Long-acting beta-2 agonists, e.g., salmeterol, are not indicated for treatment of asthma in the accident and emergency department. Levalbuterol, that is R-albuterol, is a single isomer, higher potency drug but does not offer any clinically significant advantages, i.e., improved outcomes, in most patients versus racemic albuterol to justify its higher cost. My next question reads, should QCI receive corticosteroid therapy as part of her accident and emergency department management? The correct response is yes. Because asthma is primarily an inflammatory airway disease, the degree of inflammation associated with QCI's current exacerbation should be considered. Per EPR3, if there is not an immediate response to inhaled beta-2 agonist therapy, oral systemic corticosteroids should be administered. Refer to further discussion of this subject. Furthermore, if QCI had a peak flow meter at home, earlier objective detection of the development of this exacerbation might have prevented an accident and emergency department visit. When the peak expiratory flow is in the red zone, that is less than 50% of personal best, and poorly responsive to short-acting inhaled beta-2 agonists, early intervention with oral corticosteroids is associated with a reduction in accident and emergency department visits. Refer to the outcomes section at the end of the chapter. QCI and her parents should also understand that if respiratory distress is severe and non-responsive to treatment, they should proceed to an accident and emergency department or call 911. Finally, before going home from the accident and emergency department, QCI and her parents should receive some basic education regarding asthma and its acute and long-term management. It is important to follow up with more detailed education during future clinic visits. According to EPR3, QCI should receive a short course of systemic corticosteroids as part of her discharge plan, thereby reducing her risk of re-exacerbation. Typically, Oral prednisolone solution at a dose of 1 to 2 mg per kilogram in daily or divided doses twice daily is given for approximately 5 to 7 days. Although this regimen is very effective, to improve adherence several studies have examined shorter, that is 1 to 2 day, courses of oral or intramuscular dexamethasone and have found similar results when compared with usual regimens of oral prednisone or prednisolone. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 353.